All right. Hello, everybody. All right. So I'm, as usual, doing a little multitasking over here, trying to go live on Instagram. They don't make it easy. All right. Bear with me. Okay. All right, guys. I think we're live in all the places. And I'm so excited for this conversation. Honestly, I've been working so hard on my sleep after my last conversation with the one and only wonderful Dr. Bhopal. And and gosh, we were just exchanging, notes on when the last time we connected. And it was in March, right?
Yeah.
Okay. So yeah. So let me take a step back and I'm going to give you just a quick intro to our topic today. And all right, so first of all, welcome to everyone. I'm so excited that you're joining me for this really important conversation today. And today we are going to be tackling a topic that comes up a lot, right? All the time. But I would just venture to say it can feel really challenging to address this topic with a lot of confidence. And that topic is sleep. Oh my goodness. So, this conversation is entitled The Sleep Gap What Every Healthcare Practitioner Needs to Know. And I'll just say this, if insomnia has ever felt like one of your biggest, shall we say, clinical headaches, today's discussion I think is really going to be helpful. So, I am joined by Dr. Nishi Bhopal, and she is the founder of IntraBalance LLC. And she specializes in helping healthcare practitioners and coaches understand the real drivers of insomnia so they can move beyond symptom management and into clear, effective treatment strategies that work. So, we're going to be talking about lots of great topics, including some common sleep blind spots, why insomnia is so often misdiagnosed. Very interesting, the role of hyperarousal and how simple frameworks can really improve outcomes without adding more complexity to your already full plate. All right, so I am so excited to have you here, Dr. Bhopal. Delighted. And if you could kick things off, just a little bit of background on you.
Sure. Well, thank you so much for having me. This is my favorite topic, of course. So I'm really excited to dive into sleep today. And so just a bit about my background. I'm originally from Canada, so you might be able to hear that in my accent, but I live in the San Francisco Bay Area. So my background clinically is that I'm trained as a psychiatrist. I'm also board certified as a sleep medicine physician. And I have additional training in integrative holistic medicine. So I really blend all of those different approaches in my clinical work. And what I saw over the years of practicing, so it's been over a decade now of practicing since I completed my fellowship, I've seen time and time again that many clinicians are struggling to support their patients with sleep. That is that most doctors, whatever nurse practitioners, coaches, therapists get very little training in sleep medicine. Like we're talking like an hour or 2 hours in a fundamental process that everybody has to do, right? So there is a lack of training, yet every single patient or client that you're working with has to sleep. And you're likely seeing lots of sleep issues coming up in your work on a day-to-day basis. So I saw that there was this gap in that clinical education. So that's why I started going on YouTube. I was getting all these questions from my colleagues about, I have this patient with this sleep issue and this client has that sleep issue. What do you think? So I just started packaging all of that, putting it on YouTube. And now that has led into having online courses and doing various educational lectures and things like that on sleep. And I like to make it really simple for people because it can feel kind of overwhelming sometimes and sometimes even frustrating. A client come to you and they have insomnia and you're trying all these different things and nothing is working. So what I really like to do is make it really simple so that you almost feel excited to see those insomnia patients because you know exactly what to do.
Oh, I love that. This is going to be so helpful. All right. Well, thanks for that background. Such important work. And I don't know if I realized that you were a psychiatrist. We may have talked about that before. I'm sure we did, but that is very cool. So you've got the whole the whole spectrum covered here, right? Which is
Yes.
amazing. Okay.
Absolutely. And mental health and sleep is so connected, right?
So
So we can
connected.
talk about that as well.
Okay, I want to for sure. All right, so let's kick things off by me asking you about the biggest sleep-related blind spots that you're seeing in, just everyday clinical practice.
Great. So there's kind of two big ones that I'm seeing. Okay, so the first one is that insomnia is not always insomnia. And for some reason, when it comes to sleep issues as practitioners, we often take what the patient is saying at face value. Whereas when they come in with something else, so let's say someone comes in with a headache, right? So we're not immediately saying, oh, go take some Tylenol or go take some magnesium. We are kind of going through a differential diagnosis. We might do some additional labs or workup. We'll take a more detailed clinical history to understand, okay, what is this headache about? What's really going on here? So that workup happens. But for some reason, when it comes to sleep, we jump straight to treatments without that in-between step of understanding what actually is driving those sleep issues and what is the appropriate treatment plan for that. So when I say not always insomnia, what that means is when your patient or client comes to you saying, I'm having trouble falling asleep, staying asleep, waking up too early, or I get enough sleep and I'm tired all the time, we need to look under the hood to see what's going on. And that could be something else. It could be sleep apnea. It could be restless leg syndrome. It could be a hypersomnia disorder like narcolepsy. All of these things show up commonly in clinical practice, but are frequently missed. So that's just the simplest thing I want you to think about when you see somebody struggling with insomnia. Just ask yourself, okay, what's the driving factor behind this? And we can't assume that it's stress, right? Oftentimes that's what happens.
Always, right?
Or we assume that it's hormones if it's a woman, or we assume that it's a cortisol surge in the middle of the night because of low blood sugar. All of those things could be at play, but we can't make those assumptions because there's lots of other things that could be happening. So that's the first, is that, insomnia is insomnia, but it isn't always. The second thing is that we need to understand as practitioners what normal sleep looks like. Many of us have heard that most adults need 7 to 9 hours of sleep on an average basis, right? On a nightly basis. But the reality is that most adults need somewhere between 6 and 10 hours a night. So if you have that patient who's getting 6 hours of sleep a night or 6.5 hours of sleep, and they're like, I'm not getting enough sleep, I'm supposed to be getting 8 hours of sleep. They may have heard that online or in social media. That's actually not necessarily accurate. 6 may be enough for them, or 6.5 may be enough for them. So just understanding some of these foundations of what normal sleep looks like, understanding the foundations of sleep architecture. I have more information on that on my YouTube channel. It's probably a little bit outside of today's scope, but sleep looks like, for example, I'll just share another really quick tidbit, which is that it's normal to wake up in the middle of the night. That's actually part of our normal sleep architecture. So if your client is saying to you, well, I fall asleep and I'm asleep for a few hours, then I wake up at 3 a.m. and then, I might fall back asleep and wake up again at 4 a.m. Well, congratulations, you just described normal sleep. That's what it's supposed to look like, right? Or I feel like my sleep is lighter in the second half of the night. Yes, that's exactly what it's supposed to look like. So we need to be aware of not adding more anxiety to our patients and clients, right, about their sleep, and helping them to understand what normal looks like, and then recognizing when things are starting to go awry and where we need to intervene.
Okay, I love that. So one thing that you said that caught my attention is that what we think is insomnia isn't always insomnia. Can you elaborate on that a bit?
Yes, exactly. Okay, so a few things to keep in mind. So one is, if your patient comes to you complaining of difficulty falling asleep, our goal is not to try to sedate them, right? To give them sedatives or give them supplements or things like this to make them sedated. Our goal is to understand why they're having trouble falling asleep. And there's a few main reasons that could be. It could be because of poor sleep hygiene. So maybe they are staying up too late on their screens or using their phone or what have you, and they're getting too much bright light or blue light or whatnot. So sleep hygiene is one aspect, but we also need to consider certain sleep disorders that could be at play. One of them that is common is a circadian rhythm delay. So that's just a delayed body clock. So that you'll see in your teenagers who don't fall asleep till 2 or 3 a.m. and then they can't wake up for school on time. They're dreaming. So that night owl sort of archetype, you can see that in other patients as well. So we want to be looking out for that because that's a whole other strategy to try to shift their circadian rhythm earlier. But another common reason, especially in women, that where they might have trouble, restless leg syndrome, and that can be related to low iron levels. And so if you are someone who's able to order labs, then you want to be checking their iron levels and their ferritin and things like this. So just having that idea of what are the differential diagnoses for sleep onset issues. For sleep maintenance issues, so your patient who's waking up in the middle of the night and they're having a lot of trouble staying asleep, one of the most common things to look out for that's often missed, especially in women, is sleep apnea. And sleep apnea looks very different in women than it does in men. In men, we think about the patient with the 17, the loud snoring, they're waking up gasping, their wife is elbowing them or their partner's elbowing them in the middle of the night to try to turn over, right? So they have that sort of classic picture. But in women, it can look like insomnia, right? So they're having trouble staying asleep. They're fatigued during the day. Maybe they have chronic headaches. Maybe they look like they have depression. Women are often misdiagnosed as having treatment-resistant depression, fibromyalgia, even perimenopause, right? All of these things can look like sleep apnea, or sleep apnea can look like those things. And we do know that the rates of sleep apnea increase during perimenopause and basically double after menopause. So you don't need to be overweight to have sleep apnea. You don't need to have all those classic symptoms of the snoring, the waking up, gasping, or choking. It can be kind of silent in women. So I highly, for anyone who's working with women who are having trouble staying asleep, get a sleep study. And last year, so I had 4 women referred to me who were perimenopausal, sort of like midlife. And they were all referred to me for treatment-resistant insomnia because their practitioners had done all the usual things that people generally recommend for insomnia, and it wasn't working. And so I did sleep studies on all of them, and they all had moderate to severe sleep apnea without the classic symptoms. And some of their doctors had said, no, you don't have sleep apnea. You don't have any of those symptoms. So they didn't even get a sleep study. The doctor had already decided, that she doesn't have sleep apnea. And lo and behold, they did, right? So I just want to hammer that point home, that we need to be looking under the hood to see what's going on. So that's what I mean when I say insomnia isn't always insomnia.
Okay, I see. So it is really complex. And so interesting what you said about, especially in women, that weight isn't always a variable, right? And so I kind of feel like just in general, we're, I don't know, maybe doing a disservice to women in general by kind of perpetuating that thought process that, if you're not obese or, struggling with your weight, you're probably good. You probably don't have sleep apnea, but I'm hearing the opposite.
It's the opposite. And this is a soapbox moment, right? Women are so underserved when it comes to health in general, and especially sleep medicine. And so much of the research that we have in medicine and sleep medicine specifically is centered on men. And so we just, now there's an emerging interest in women's health and women's sleep health. But some of the reasons why women might have sleep apnea that's not weight related is because we just have a shorter airway. So it's more susceptible to collapse, right? And then we also have hormone fluctuations. And especially during perimenopause and menopause, with that decrease in progesterone, which helps to keep the airway open, that decrease makes the airway more collapsible. So it's not necessarily because of weight. There's just other factors that could be contributing.
Oh, so interesting. Okay. So, and I do want to just mention, I have had 2 sleep studies recently, and for a variety of reasons. And I was sharing with Dr. Bhopal before we went live a little bit about me. I got an Aura ring, and I would like to chat a little bit about, the accuracy of um, these little gadgets in terms of sleep architecture. But nonetheless, I just want to, public service announcement here. It's so easy to get a sleep study, right? You don't even I know years ago I had one and I had to go to a sleep center and it was kind of a big ordeal, to be honest. But nowadays, you can just go through your medical system, you get it sent, or in my case, I had to go pick it up. All right. But that wasn't a big deal, right? You just go pick it up, do the study. It's so easy now. Anyway, so that's the main point I want to drive home. It's not a big deal. So easy.
I'm so glad that you mentioned that because it is so easy nowadays that you can do home studies, and home studies are more accurate than they were even like 10, 15 years ago, like when I was doing my training. So I recommend, like, if you're working with somebody and you suspect there could be something like this going on, just get the sleep study.
Yeah.
They're not as expensive as they used to be. You can do them at home. And then if it's negative, but you still think the patient might have symptoms, then you can refer them to a lab study. And, you can refer to your local sleep clinic and they can help you do that. But don't hesitate to recommend it because, like you said, we are doing women a disservice by not exploring that aspect of sleep.
Yeah, absolutely. And it really was so easy, and, insurance covered it. So really pretty, just feels pretty easy and straightforward nowadays, especially compared to 10 years ago, where not so much. So, do you have any other comments in terms of why so many clinicians kind of feel stuck when it comes to working with insomnia and, just, I guess, diagnosing and treating sleep issues in general?
Yeah, and I think it goes back to what we were discussing earlier, which is just the lack of education that we receive on sleep. Like, I remember when I was in my residency training, we got a little bit of information about restless leg syndrome. Like, I remember one lecture on that. We got like 1 or 2 lectures on sleep apnea, and it was all focused on like the classic presentation, like the snoring and all the things, but really not much more than that. And then a lot of training on like sleep pharmacology, so sleeping pills and what to prescribe and stuff like that. That was about it, right? Maybe hopefully it's changed. That was, back in 2009, 2010, that, 15 years ago, 15, 16 years ago. But I think that is one of the reasons is we just don't get enough training. And the other challenges is that patients and clients are much more aware of their sleep these days. Like, again, back when I was in training, the ethos around sleep was, I'll sleep when I'm dead. I don't need sleep, right? That's like how people, like, that was the perception of sleep, like, whatever, it's a waste of time. Now that the tides have turned, where people are so interested in sleep to the point where they're anxious about it, they're tracking it, right? I'll have patients come in with their Oura Ring data, their Fitbit, Apple Watch data. People are hearing about it on podcasts. Melatonin use has increased multiple fold over the past few years. The sleep supplement industry is now a $7 billion industry globally, right? So people are a lot more interested in it. So clinicians don't get the training that they need. And then they're seeing all these clients who are coming in concerned about sleep and tracking it. And then you're left as a clinician going like, okay, where do I start? What do I do with this? Because you've got a million other things you need to work on with that client as well. So I think that's where there's that disconnect, that gap.
Okay. So let's talk a little bit about the hyperarousal. I'm really curious to better understand, first of all, what exactly is that? And how does it impact sleep?
Great. Okay. So I'm just going to zoom out a little bit and just give you a framework to think about when you are working with a patient or a client who has sleep issues. So the framework is what I call the CSH framework. And what these stand for is C is circadian rhythm, So that's your body clock, that's your sleep-wake cycle. So that tells your brain when it's time to be awake and when it's time to be asleep. The S in the CSH is your sleep drive. So this is like hunger. The more you go, the longer you go without eating, the hungrier you will be. Mm-hmm. So sleep drive is like that. The longer you're awake, the sleepier you'll be later. And then the third thing is the H, CSH. H is hyperarousal. So that's your nervous system. So if you have nervous system activation, that could be from stress, it could be anxiety, it could be from a sleep disorder like sleep apnea that we talked about, from a thyroid imbalance. So anything that's creating that sort of nervous system activation, elevated adrenaline and cortisol, is going to override those first two systems, the C and the S, the circadian rhythm and the sleep drive. So what you want to do is when you have a client come to you struggling with sleep, just go through those 3 steps, assess their body clock. What time do you wake up? What time do you go to sleep? When do you feel sleepy? Do you have a consistent schedule on weekdays versus weekends? Things like this. The S is, well, tell me about how much time you're spending in bed. How active are you during the day? Coffee actually suppresses that sleep drive, caffeine rather. So any sources of caffeine suppress that sleep drive. If we have time, we can get into that as well. But you can do that assessment. And then the H is that hyperarousal. So let's talk about your nervous system. Are you on the go all day? Patients call the go, go, go club. They're on the go all day long, jumping from one thing to the next, one meeting to another, dropping off the kids, this kind of stuff, right? And then at the end of the day, that's the only time they slow down. And then what happens? Their mind is off to the races because it's like the only time they've had to themselves. So your nervous system doesn't just go from on to off, right? There has to be an off ramp to calm down. So that's the hyperarousal piece. So we need to be looking at all 3 of those pieces to really understand what's at play for that patient.
Oh, so interesting. Okay. So a little bit of, relaxation during the day can go a long way is what I'm hearing.
Absolutely. Like even just like building in like little snacks, relaxation snacks, just a few moments of breathing, walking, so that we can activate that parasympathetic nervous system, that calming aspect. So it's easier for your body to get into that at night.
Okay. So, what do you have any thoughts around, there's so many gadgets nowadays, and I'm kind of a gadget sort of person, if I can like maybe find a shortcut, I'll sign up for it if if it sounds like it's going to work, right? So, do you have any thoughts on some of these gadgets that we're seeing that claim to stimulate the parasympathetic nervous system?
Yeah. So, on the topic of gadgets, so the first thing I'll think about is like trackables, like wearables that track your sleep, right? So like Oura Ring. Oura Ring is, I'm actually taking a break from mine. I usually wear one as well, but like I think it's good to take a break from trackers once in a while. So I'm not wearing mine right now, but Oura Ring can be really useful. So can some of the other. And from a clinician standpoint, if you are working with a patient who's using them, just a couple things to know. One is those trackers can be really helpful for implementing behavioral change. So for example, I'll have patients tell me like, oh, I can drink coffee at 6 p.m. or like a glass of wine doesn't affect my sleep. Okay, well, let's look at the wearable data and then you'll see over time, like your heart rate variability goes down, right? Their sleep quality isn't as good. So you can use the tracker data as a impetus for behavioral change. Right? For that, you can use that in your coaching. But do take the sleep staging data with a grain of salt, because you'll have patients come to you saying, oh my God, my REM sleep was only 2%, or my deep sleep was only this 9%, or whatever. That data is not accurate. You can't really measure sleep stages from a tracker. Not yet, anyway. The technology isn't there yet, because sleep stages is based on EEG, right? It's based on brain waves. That's how we determine a sleep stage. So you can't really get that from a wearable that's on your ring, on your wrist. So just you take that with a grain of salt, so people know. Now, in terms of other gadgets, I hesitate to make recommendations because I think for a lot of our patients and clients, they're looking for something external when really it's like the simplest behavioral changes, and then looking at the sleep disorders, making sure that they don't have those that move the needle the most. And then where gadgets can fit in is as an adjunct to help with that, but not to be like the thing that works, if that makes sense.
It does.
Okay. So one of the ones, actually, I wish I had it here. I have it in my other room, is wearable light therapy devices. So one of the most impactful things that you can do to improve your sleep is to get bright light in the morning and during the day and night. And I'm lucky to be in California, so we can go outside and get some bright sunshine during the day. But if you're in a place, like I grew up in the Pacific Northwest, like in Vancouver, BC, it's very dark. I just came from there a couple of weeks ago, and I was like, oh my God, it's so dark in the morning. And so if you live in a place like that, then a light therapy device can be really helpful for the circadian rhythm. So like a happy light, as many people refer to them, so like a light box type thing, or a wearable. And I like the wearable ones because you can walk around. You don't have to sit straight in the box. You can walk around, make your coffee, have your breakfast, do all that stuff in the morning. So I do like those gadgets, and those are evidence-based. They're effective. Other gadgets, I mean, I know there's lots of things out there, like different types of mattresses and things like that. There's like Alpha Stim and these types of wearables, or, whatever gadgets. Those have less evidence. I have had patients try and use them. I've seen mixed results. I don't know, Leslie, if you've like seen good results with some of these things. So I don't know. I really just like to inquire with the patient about what's really going on. And, is there a scope for using some of those things? Was there anyone that you had like a specific question about?
Well, I am trying the NeuroPod, which goes on the left ear right here. And then also one called the Pulsato. So kind of that two-prong approach. And, let me just say, according to the Aura Ring, which you just said is not super accurate in terms of measuring sleep stages, my deep sleep has improved like a lot. But who knows, right? Who knows? But like I said in the beginning, I've worked pretty hard to try to improve my sleep, and just really like trying to go to bed earlier, trying to read before bed, just, really trying to hone in on how I can improve my sleep overall, right? Trying to, even though it's so cold here where I'm at, I bundle up and I try to get outside every day, even though you don't see many people walking around, but, I'm bundled up trying to get, some sun, what little sun we have here, trying to soak it up. Right. So, yeah, I think it's more of a combination of different approaches that has seemed to really help me. But again, I don't know. It's hard to put my finger on whether or not these gadgets are, I don't know if it's placebo. I don't know, but I do feel better. So there's that.
That's great. Yeah, that's great. And so I think you really just hit the nail on the head when it comes to gadgets. So again, for the practitioner, if your patient comes to you and asks, so I did have one patient ask me about the Pulsetto.
Okay.
And they tried it and they were like, and this patient had chronic insomnia. Okay. And they also had recommended to like a family member of theirs who had chronic insomnia. So this is only two people. Yeah. They both tried it and they were like, meh. Right. So, okay. But what you just explained is so, so important. So as the practitioner, if your patient comes to you and asks, what should I use, this device, that device? First, we start with all the basics that Leslie was just talking about. So getting exercise during the day, getting the bright light, you got your sleep studies to make sure, there's nothing medically that needs to be addressed that's being missed, right? So we start with all of those basics, the C, S, H, we work on those three pillars. Then if you want to add in a gadget for additional support, or if you want to use a tracker, a wearable to kind of see if they're affecting you, great. I'm not opposed to that at all. If it's helping you, then that's wonderful. The population that I work with, we have a program called Effortless Sleep. It's called Effortless Sleep in 6 weeks, and it's for the patient who has chronic insomnia. So The challenge is that people might be seeing in their practice is that when you have that patient or client with chronic insomnia, they are trying so hard to sleep, right? Like they're usually doing all the right things, or they have better sleep hygiene than I do, as a sleep doctor. Like they're doing all the things, they're trying really hard, and they're like, okay, I'm going to try this gadget, I'm going to try this supplement, I'm going to do this. What's the right type of magnesium? What's the right type of melatonin, right? Like they're trying so hard. And the more you try, the more you activate your nervous system and you activate that hyperarousal. So just be on the lookout for your patients who are doing that. Because my patients who don't have that, they're like, oh yeah, they kind of have fun with the gadgets and the trackers. But the patients who have chronic insomnia, it becomes a source of stress for them.
Oh yeah, I can see that.
Yeah. And so in those cases, I'll say, you know what, let's put all of that stuff aside and let's just work on regulating your nervous system. And the analogy I like to use is that it's like swimming, because if you're swimming and you want to float, what do? You do nothing, right?
True.
You just lay there on your back and you breathe and you just let the water hold you up, right? You do nothing. But the more you thrash around and try and like hold on to this thing and that thing, you're going to sink. So sleep is like that. We want to shift from effort to effortlessness.
Okay.
So I just wanted to make that.
That's so good.
So it's so important with insomnia. Yeah.
It can be counterintuitive, right? Like you think, okay, I'm going to really hunker down and master this. But then that can obviously, as you said, backfire for people because, you're just putting in so much effort and it's backfiring. You're just trying too hard, which makes sleep harder to achieve.
Yes. Yeah, sleep is a passive process. Like there's a lot of active things that happen physiologically during your sleep, but the act of falling asleep and staying asleep, it's passive. So as the practitioner, sometimes we take on that anxiety of the client. We start trying harder. Why don't you try this supplement? All right, let's try this medication if you prescribe medications, or let's try this other technique. Let's do this meditation technique or whatever it is, right? And so we start getting anxious because the patient comes back and says, well, that didn't work. Now you're looking for the next solution. Okay, let's try this next. Right. And it becomes almost where they're anxious, you're anxious, they're frustrated, you're frustrated, and we're actually unconsciously feeding into that chronic insomnia.
Yeah.
So we also have to be really mindful of how we're talking to our patients and clients about their sleep.
Okay. Are there any other like kind of simple shifts that our clinicians and practitioners here can make right away to improve those sleep outcomes?
Yes. Okay. So the first thing is having some kind of an intake form that goes into the detailed questions that might help you assess if there is a sleep disorder underpinning the patient's sleep issues, like if there's restless leg or something like that. You don't need to be trained in how to treat those. You don't need to, know what all of the management protocols are for those things, but at least you can flag them so then you'll know if you need to refer them out to a sleep specialist. So that's the whole idea. So what I would recommend is in your intake forms, you can include some of those questions. And if you Google the AASM, American Academy of Sleep Medicine, sleep history template, you can get a free PDF. Like it's just free to download and just put those questions into your intake form. And that's no extra time for you in your clinical visit because the patient can fill it out beforehand, or you can send it to them after and then they can fill it out. So I recommend doing that. That's just a simple thing you can do. The other thing that I do recommend is wherever you're working or practicing, make friends with the sleep specialists in your community.
Okay.
Get to know your local sleep doctor, your local sleep psychologist, or whoever, your sleep clinic. Develop a relationship with those practitioners as well, because medicine, wellness is a team sport, right? You don't have to be doing everything on your own, and have someone that you can consult needed. So those are just two really simple things that don't take a lot of time. And then the third thing is to use that CSH framework. Just go through that checklist in your mind even. Is their body clock irregular? That's something that you can work on then. Are they spending too much time in bed, or are they too sedentary during the day? they need to be a little bit more, like, are they sitting at a desk all day? Maybe they need to get up and go for a walk. So the sleep drive, and then assessing their caffeine, and then the hyperarousal we talked about.
Okay. So interesting. And what is your recommendation? I'm always curious about caffeine. According to my genetics, this is just me, I'm a fast metabolizer. So I operate on the impression that I'm good. I could maybe be one of those people. Not that I do, but maybe I could, drink caffeine at 6 o'clock and be fine. But my guess is that's probably not the case.
Yeah, so it's interesting. So for most people, like the metabolism, like the half-life varies on for each individual. So for some people, it can be up to 12 hours. Like I'm someone who's very sensitive to caffeine. So if I have caffeine after 3 p.m., like I know I'm not going to sleep well that night, right? So, and I come from an Indian family, so like they have their tea time at like 4 or 5 p.m., like their masala chai. And so it's like if I'm visiting family, it's like I know I'm just not going to sleep well if I participate in that ritual, right? So that's the first thing, is just helping your patient understand how it impacts them. As a general guideline, I recommend no caffeine after noon, after 12 p.m., especially for the person who wants to optimize their sleep. If they're worried about their sleep, let's try that. Try it as an experiment.
Yeah.
And I like to do things very gently, because if we give people hard and fast rules, it sometimes activates that anxiety. So what I would suggest is I'll recommend to a patient, let's try caffeine after 12 p.m. Let's do that for the next couple weeks and see how that feels. And what do you think? Is that something you want to try? And oftentimes they'll go, yeah, sure, that sounds good. Right. So like we don't need to be implementing like thou shalt not have caffeine. Like it doesn't have to be like the 10 commandments, right? But we can introduce those ideas gently.
I love that. All right. Do you have anything else that you'd like to share in terms of your frameworks in, how they help clinicians in terms of just, becoming more confident to assess and work with these patients?
Yeah, absolutely. So a simple thing you can ask your patients if they come to you and say, like, I can't sleep, just ask them, well, why? Right? It sounds so obvious.
Wow.
Why? Yes. Tell me why. Why do you think you're not sleeping well?
Okay.
And if you let them talk, often they'll tell you the answer.
Mm-hmm.
Right? Like, just jump to like, okay, this is the differential diagnosis. Just let them talk and share.
Okay.
And you might be surprised by what you hear sometimes. So for example, I had a patient who had come to me after over a decade of struggling with sleep issues. And she must have been in her late 40s, early 50s by the time she came to see me. She had been prescribed all kinds of sleeping pills. At that point, when she came to see me, she was taking Zolpidem or Ambien. And, nothing was really helping her. And so she was referred to me. And so I asked her, well, tell me about why do you think you can't sleep? What's going on? And the other question I like to ask is, tell me about where you sleep. That's something that's often missed.
Oh.
So why do you think you can't sleep? And tell me about your sleeping environment and what's it like? Walk me through that, right? That's usually how I just introduce the conversation, open the conversation, and let them go. And what she told me was that she, we're in the San Francisco Bay Area. She lived in a studio apartment, and she was sleeping in her closet because there was no rooms, right? It was a studio. Oh. So she didn't have a bedroom. So she's like, I just put my bed in the closet. Oh. Okay, well, tell me about that. Well, there's no air, like there's no windows, right? There's no circulation. It's depressing. It's stuffy. She couldn't breathe.
Oh my goodness.
Okay, well, do you like sleeping in there? Well, no, it's like kind of uncomfortable, but like I don't have any other room. Simple thing. So what we did was we had her move her bed out of the closet, set up a nice little screening divider thingy. Yeah. So she felt like she had a little bit of a bedroom space. Open the window before going to bed, get some air. And even that alone, just creating that beautiful environment, it helped her, like within a few days, she was sleeping better, right? It wasn't the only thing, because I also tested her for sleep apnea, which she had.
Okay.
She hadn't been
to it, but still, like, we gotta start with the basics.
Start with the basics.
Right?
Yeah.
Wow.
And you may be surprised. Like I had another patient referred to me by a psychiatrist, again, for, treatment-resistant sleep issues. And, okay, tell me about your evening routine. Tell me about your sleep. Why do you think? well, they were really stressed out and they were drinking like 4 whiskeys every night. And
Oh,
it's like, okay, well,
oh,
there's some low-hanging fruit to start with, right?
yes.
So
I like
simple
that.
things.
Low-hanging fruit. That's
Yes.
great.
Yeah. Yeah. So start with those things.
Okay. So, yeah, obviously alcohol, and that's kind of, no judgment, but that's kind of high volume, right? It
Yes.
does not help your sleep. Let's just put that out there, right?
Correct.
It is
Yeah.
not going to help your sleep. I know. Yeah, we won't even go there, but I'll just say this. I am such a lightweight. Like, I just can't. I can't just because I know I'm
No.
not going to sleep and it's just not worth it. Even the
It's,
smallest little bit is really impactful. So
yes.
I can put away the caffeine maybe theoretically, but definitely that other part of detoxification, not so much.
Not so much. Yes, exactly. Same for me. I know that if I even have one glass of wine or even
Yeah,
half a glass of wine before bed,
yeah.
I'm not going to sleep as well, and that will be reflected in my heart rate variability on the Oura
Oh,
ring, right?
interesting. Okay. So that is a really
Yes,
good point as well.
yes,
Hmm.
yeah,
You don't
and
sleep well, and it really has a negative impact on HRV.
yes, and setting those expectations for patients that we're not trying to achieve perfect sleep. There's no such thing.
Hmm.
And again, this is where it's really important how we speak to our patients and clients about
Sure.
sleep, because sleep fluctuates from night to night. It's not like every night you're going to get your 7 hours or your 8 hours or whatever your baseline sleep need is. Some nights it's going to be a little bit less, some nights it's going to be a little bit more, and it's going to fluctuate depending on what you did that day. If you're on vacation and you're having a margarita
Sure.
or whatever, or you had that cup of masala chai with your family at 4 p.m., it's going to have an impact, and you have to live your life too, right? Like, so we
Mhm.
have to allow for that flexibility.
Oh, that's such a good point. Yes, we don't want to become so rigid that I would imagine that rigidity is going to potentially contribute to, getting really maybe overly anxious and uptight about sleep, which is kind of a perpetuating vicious cycle that you had
Yes.
mentioned earlier, right? So, yeah, that makes a ton of sense. What? Yeah, let's talk a little bit about resources and next steps. Because I think we've definitely hit on a topic that's of great interest to the practitioners and my audience. And I'd love to be able to, um, you know, send them someplace to be able to learn more about you and your work. I think you mentioned you have a free course. Is that correct?
Yes, thank you so much. Yeah, so I do have a free sleep mini course for
Great.
practitioners. And it'll give you some of the basics and foundations that you need to know. So you can get that at intrabalance.com/doctors. And you don't
Oh,
have to be a doctor for the course. So you can
okay.
be any type of, it's for healthcare practitioners. So whatever your healthcare background is, you can
Okay.
learn a lot from that course.
Okay. So and it's DOCTORS spelled
Yeah,
out, right?
yeah.
Okay. Hang on one second, guys. Doctors. Okay. So I'm going to post that so everyone can see. All right. Let's see. Yep. Did I spell that right? I think I did. All right, awesome. All right, guys. So here is your call to action. Let's help our patients and clients improve their sleep. And as Dr. Bhopal so eloquently stated earlier, we really, we didn't get a lot of training in this. So let's kind of beef up our knowledge around sleep so that we can help our patients and clients and ourselves, right? Many of us also could use a little boost when it comes to sleep. So, really want to encourage everyone go to intrabalance.com/doctors. I know I'm going to grab that course myself. Sleep is just so important. And we know that many of our clients and patients are struggling. What is the number one symptom that you often hear from patients and clients? I'm so tired, right? I'm so tired. I'm just dragging. I can't get through the day without loading up on caffeine or carbs or, whatever they do. And so we know it's a really significant struggle that many, many people have. And as we've learned, there's lots of reasons behind it. So one big takeaway is just asking like really straightforward, simple questions like, why? What's happening? And just that alone is really going to open a good dialogue in terms of honing in on what's happening. And so many pearls of wisdom today. Any final things that you'd like to share before we start to wrap up, Dr. Bhopal?
Oh, well, thank you so much for having me. And this was really a pleasure. And I guess the final takeaway is that sleep issues are highly treatable.
Okay.
So, because I think it feels intangible sometimes, like kind of like, oh, like how do we even handle this? But just starting with that framework, the CSH framework, making friends and relationships with the sleep providers in your community, those two things can go a long way. And sleep issues are highly treatable.
Okay, that is so key. Yeah, because, I think we assume that it's just so challenging and like what can be done about it. Other than, and I know it all depends on the diagnoses, but a lot of people have an aversion to like a CPAP and things like that, but there's so many other options available nowadays. So, it's not like a straight line, a through line, right to that. There's a lot of gray area in between.
Yes.
And a lot of different options along the way. And just a reminder, it's so easy to get a sleep study now. I was truly shocked at just the simplicity of it, and it was so fast and just super valuable. Gosh, I mean, is there a recommendation nowadays for like who should get a sleep study nowadays?
Yeah. Great question. Okay, so anyone who has the classic symptoms that we talked about, the snoring, their partner notices they stop breathing or what have you. So for sure, anyone who has hypertension, high blood pressure, should get a sleep study. Especially if they are on multiple medications for high blood pressure, it's just not controllable, definitely get a sleep study. And then for your women, look out for some of those other symptoms that we talked about. So the is not responding to some of the other conventional management strategies that we talked about. If that insomnia is not getting better, then sleep study is recommended.
Okay, interesting. And what about just like feeling fatigued?
Yeah, so fatigue can be another reason to get a sleep study. Again, if you've tried all the usual things and you've checked their thyroid and all of those things, and it's not improving, then the key takeaway is have a low threshold for it. Like there's no reason to wait years.
Okay, yeah.
You know what I mean? Like if you think there might be something at play, get the sleep study. There's no harm in knowing. What I tell my patients is, let's just do the test. And then if there is something to address, then we know that. And if there isn't, great, we've ruled it out, right? So keep it simple.
Yeah, that kind of information is really powerful. So, okay, I love that. All right, guys, so we're going to wrap up. I love this topic so very much. I cannot thank you enough for taking the time out of your busy schedule to educate us and help us learn about this critical topic. So again, I just want to remind our audience, everyone, go ahead, go to intrabalance.com/doctors, and you will find a complimentary little mini course on sleep. And it is specifically targeted to practitioners. So I know I'm going to do that as soon as we wrap up here. I can't wait to dig in myself. So, all right, guys, have a great rest of your day. Thank you for joining. And again, Dr. Bhopal, really appreciate your time today.
Thank you so much.
Okay. Thanks, everybody. See you next time.